Okay, hello to everybody. Have a good evening. I think we can be able to start. We have right now 56 participants and some more are coming. Today, we are going to talk about the bladder bowel dysfunctions and the use of urotherapy on these bladder bowel dysfunctions. Well, it's really important because in epidemiological terms, they affect a significant percentage of children and adolescents considered healthy from the urological point of view. And most of the children, they do not have structural alterations in genitourinary or neurological systems, but they can be exposed to complications such as incontinence, associated dermatitis, incomplete bladder emptying, urinary tract infections, vesicoureteral reflux, and impairing upper tract functions. And moreover, these bladder bowel dysfunctions has a really very negative impact on the psychosocial dimension, and it can lead to social isolation, anxiety, or depression. And today we are having a very special guest, Anka Nieuwhof-Leppink. Anka is a pediatric nurse and psychologist, and she is the coordinator of the urotherapy department at Wilhelmina Children's Hospital. It's a part of UMC Utrecht. And she is right now, as far as I know, the head of Dutch education program for urotherapists. And she has also a very important role. She's currently a board member of the International Children's Continence Society and member of the European Society for Pediatric Urology, and also the European Society of Pediatric Urology Research Committee. And she's going to tell us how to perform a urotherapy in a pediatric urology clinic. So Anka, we are really very happy to have you tonight. So the podium is yours, and we are waiting a lot to hear from you regarding the urotherapy in children.
Thank you. Thank you for the nice introduction. And thank you for having me tonight in your seminar. I will start sharing my screen. So yes, thank you for the nice introduction. Indeed, I am the head of the urotherapy department in Utrecht, the Netherlands, and I'm working as a urotherapist for over 15 years. And 2 years ago, I got my PhD on urotherapy. So I think I can say I'm a specialist in urotherapy. Don't think that you will master urotherapy tonight. I'm teaching a lot of nurses, and I taught a lot of nurses last years, and you don't master it in half an hour. It takes a couple of days to understand, and it takes at least a year to understand all the details and practical aspects. But it's my pleasure to inform you about urotherapy and about the bowel and bladder dysfunction tonight, and to give you an overview what's at least needed, what you to improve your care for children with bladder and bowel dysfunction. And I know it's not a topic for surgeons. It's more psychological and it's more conventional therapy, but every urologist and every pediatric urologist will see children with incontinence. So if you don't have the fully interest in it, please look around and see if you can find nurses or physiotherapists who are more interested in it and can be an expert in your clinic as well. So, and if we talk about urotherapy, we talk about care for children with lower urinary tract dysfunctions, or in other words, bladder bowel dysfunction. And that means that we don't talk about children with anatomic problems or neurogenic bladder causes or urinary incontinence. I have to be honest, I also treat sometimes children with extrophy and also sometimes with spina bifida, but that is another topic. But in generally, urotherapy is for children with a low urinary tract dysfunction, and it means there is a presence or absence or an amount of frequency of incontinence, voiding frequency, urgency, voided volumes, fluid intake, urinary tract infections, and deviated stream. And if we talk about the prevalence of incontinence, and then we talk about daytime incontinence, I don't talk about bedwetting tonight, and I don't talk about treating bedwetting, and I will not talk about the assessments and the invasive assessments like urodynamics. But if we talk about urotherapy, we talk about treatment for children with daytime incontinence in generally. And when we talk about the prevalence, we have school-age children, we talk about school-age children, and the prevalence is about 6 till 9%. And there are also literature who pointed out to 14%. And it decreases with the age, but still we have adolescents with incontinence problems. And we know that daytime incontinence is exists more in children with behavioral problems like ADHD or autism. And we talk also about constipation and fecal incontinence, and also the number is high rated till 30% prevalence, and 80% of fecal incontinence has constipation. And we always explain parents when they come to our clinic, okay, you're coming with your child with urinary incontinence, but we also focus on constipation and the bowel, and that's not what the most of them expected, but it's needed for your success of treatment. And I'm very strict, because when we talk about incontinence, we don't talk about not toilet trained, we talk about functional incontinence. And there is a huge difference between children who are not toilet trained or children with functional incontinence. When we talk about not toilet trained, these children has a complete voiding at an inappropriate place, and they are dry between each voiding, between each voiding. And if they are not becoming toilet trained, they could have problems in perception, or they could have problems with the motor control, or they could have problems with the cerebral or neurological problems. But not toilet trained is often a maturity problem. And if we talk about functional incontinence, we talk about loss of urine between each voiding, or loss of feces between bowel movements. And it could exist on different types. It could be because it happens on urgency. It could happen on overflow. It could happen on high pressure. It could be dribbling incontinence, or giggle, or stress incontinence. So this is important for parents, but also for psychologists, because my experience is that a lot of psychologists, they talk about not toilet trained, but when we talk about incontinence, we talk about functional incontinence, and there's a huge difference, and there's another way of approaching the children. When you have to train a child for toilet training, then you will coach the parents, and if we want to help the child with incontinence, we will train the child. And as said, we have different subtypes, and this is important also for your treatment. When we talk about incontinence, we talk about anuris nocturna, and then we have the monosymptomatic anuruses and the non-monosymptomatic anuruses. The monosymptomatic anuruses means that there are no other complaints, only bedwetting at night. So they have no urgency or frequency during the daytime. They have solely bedwetting at the night. And when the child has also urgency or UTIs or dysfunction avoiding, then we talk about, and also bedwetting, then we talk about non-monosymptomatic. We have the fecal incontinence, and it could be retentive fecal incontinence because there's constipation, and the solitaire fecal incontinence. And this is a very difficult group to help these children. And then we talk about daytime incontinence, and we differentiate between 4 types. We differentiate between the overactive bladder, dysfunctional voiding, the underactive bladder, and the postponement. And also this is one of your key points to start your treatment. When you start your treatment, you have to understand what different type of problems the child has. And when we talk about the overactive bladder, there are some classifications. The child has a frequent urgency to void. So if you have a child who is drinking less, for example, 4 glasses a day, but voiding 8 times a day, then there is a higher frequency. And also the children has a lot of often holding manoeuvres, and urges are counted by posturing or pelvic floor contraction. So this is not an overactive bladder or an overactive detrusor where they can prove with urodynamics. This is often the difficulty for medical doctors, because they say, I don't know if there is an overactive bladder if I haven't done urodynamics. But according to the ICCS, we say when there is a frequent urgency to void and a high micturition frequency, then we can talk about an overactive bladder, if they have also a normal bell-shaped pattern on the uroflow. It is not always necessary that these children has also incontinence. There are children with an overactive bladder who can be completely dry during the day, but it is a very disturbing when they have to go so often to the toilet. So it will also have impact on their quality of life. And have in mind the constipation. When we talk about dysfunctional voiding, it's a disorder of emptying. It's a failure to relax the sphincter during voiding, and that's why you always have a staccato or a fractionated flow pattern when the child is voiding on the urophilometry, and you will see a normal amount of urine of maximum voided volumes. These children have often incontinence, and it's due to the pelvic floor. They lose the awareness of their bladder feeling due to all the time contract their pelvic floor. So that's why they become wet. And you can understand that these children has also more constipation because when you are walking around all the time with a contracted pelvic floor, you also hold your bowel. And these children have often UTIs due to the post-void residuals because they are not able to void in a proper way, in a relaxed way. And you can see it also in the pictures which I got from Alexander von Contet, psychiatric, now from Switzerland. And the underactive bladder, it's also a disorder of emptying, but it's due to the weak detrusor contractions. And these children has a low amount of voids. They have often incontinence due to the overflow of the bladder, and they can also have constipation, and they have post-void residuals, and therefore also often UTIs, and also frequent big volumes to voids. And the voiding postponement, this is a condition which can present both as a symptom and as a condition, and you will often see this in children with HDHD and younger children, but they have a complete normal flow pattern, and they have normal bladder volume, and when they have urgency, they will have it due to postponement. And this is the difference between the overactive bladder. The overactive bladder children, they will have the urge because of the contraction of the detrusor, and this is difficult to hold, and these children are postponing, and then they will see urgency. But for parents, it's not always always easy to understand what is the urgency. Is it urgency, especially with the overactive bladder children, when you explain to parents, these children, they have holding nervous. Lots of parents and grandparents, they said, well, I can see you have to go to the toilet, so why are you not going? But the contraction of the detrusor is so strong that they are not able, they are trying to hold, and then when they and then the bladder relax, and then the urge is going away, waning away, and these children these children have a lot of battle with the parents, because the parents don't understand that it is not the child's choice not to go. They are not able to go when they have the strong urge feeling of the bladder. And this is important to explain parents, that they are not blaming their child. And as I said, we have the crosstalk between bladder and bowel. We know that children with dysfunction of voiding and the underactive bladder, that almost 80% of them, they have a full rectum, and the children with an overactive bladder, they have often a full rectum and are constipated. Officially, you should use the aroma 4 criteria to diagnose constipation, but we always said, as urologists, as in the urology department, we are not happy with the bowel, but it's involved, and it will also compress the bladder. And if you don't solve the full rectum, then you don't know exactly what the cause is of the detrusor or the urgency, the detrusor contraction or the urgency of the child, of the bladder of the child. And if you have functional incontinence, we know it's the heterogeneous causes of bladder and bowel problems, so that's also why you need a team. You need a team approach. You cannot do it by your own. You need at least nurses or physiotherapists and a psychologist to treat these children in the best way. As said, I don't want to talk much long on the tools of investigations, but you need at least a good to take a history, to ask the medical history, and also the psychosocial history, because as we know that there is an interplay between behavioral problems and also the bladder, you have also to know the psychosocial history, and you have also to ask about abusement, sexual abusement or bullying, because a lot of these children are bullied too, or have experience with bullying because of the wet pants during school times, or because they have to go so very often to the toilets. And you never can start any treatment when you have not taken or asked the parents to fill in a bladder diary. This is always very difficult, because a lot of parents don't understand why they have to fill out a bladder diary. But if you want to know if there is a small bladder volume or urgency, you have to compare it, the output with the input. So you have to know how much is the fluid intake, and how often is the child going to the toilet, and what's the maximum voided volume. So no start a treatment without a bladder diary. And if parents are the first time in your clinic, please explain why it's necessary and let them come back. Clinical examination is important to rule out the anatomical or neurological problems, and you need a uroflow and an ultrasound in your clinic to see what type of incontinence you're talking about. And the general treatment principles are that at least the child should be above 5 years old, and our preference in the clinic is above 7 years old, because younger children, they don't have a body awareness, a full body awareness of the bladder, and you can explain them how it works, but they don't understand it, and they're not able to follow up the rules and the instructions which you gave to the child. So when you have a child between 3 and 5 years old, we can support parents, and you can see if there is a very overactive bladder, you can treat it with anticholinergics, but don't start urotherapy or physiotherapy in these younger children. And treatment should be always symptom oriented. If there's ADHD or autism, please, it should be treated as well. And you always start with treating the constipation, and the second step is that you start to treat the daytime incontinence, and the third step is that you treat the inerters, and that's also reasonable when you understand that if there is a crosstalk between bladder and bowel, and there is a full rectum, that I can start treating the child with daytime incontinence, but it will not resolve if there is still constipation. And we know also that if we treat constipation and daytime incontinence quite well, that a lot of children have less enuresis. So it's really worthwhile to follow this sequence. We published almost 2 years ago this paper because about the definitions and indication and practice for urotherapy, and urotherapy started in the 80s, 90s, the early 80s, and in the early 90s with Anna-Lena Hellström and my former colleague Marianne Vijverberg. Anna-Lena Hellström was from Sweden, and my former colleague in Utrecht, and they started with relearning and training programs for these children, and they also started with they wrote the first publications on the bladder training programs. The aim of urotherapy is that we want to cure or alleviate incontinence and the comorbid symptoms of LUTS, so like urgency, like UTIs. And you always start with standard urotherapy, which I will explain what it is, and then most of the children will have benefits with standard urotherapy, and then you'll do the next step. When the standard urotherapy is not sufficient, you will start with urotherapy, and then the end, specific urotherapy, and in the end, for some children, clean intermittent catheterization is needed. But it's a very practical paper and useful when you to have it on your desk when you treat children. And the elements of urotherapy are many, but we use a biofeedback, and lots of colleagues around the world, when you talk about urotherapy, they think, oh, urotherapy is biofeedback. Why that is, I don't understand, because biofeedback is just a part of urotherapy, but I think it's the most understandable part of urotherapy. They think, okay, they need to learn how to rehabilitate the pelvic floor, but urotherapy is much more. It's encouragement, it's lifestyle advice, it's bowel management, its explanation. I think the biggest part of urotherapy is explanations to the parents and information and instructions to the child, and it's behavioral modification and based in cognitive behavioral therapy. So that's why urotherapy seems easy, but is sometimes puzzling with children, because sometimes you have to focus more on the cognitive behavioral therapy aspect, and sometimes you have to focus more on biofeedback, and sometimes it's just a lifestyle advice. And we follow a well-structured and bespoke and purposeful process. This is important also to understand when treatment failed, why it is failing. So you start with the introduction. We start to understand what kind of problem definition is. We start with to talk what is the request for help, because a lot of children, they are not coming to the clinic. They need help. It's most of the time the parents, they are concerned about their children, so they want help. So and I know in Turkey, it's also happens that a lot of doctors, they talk to the parents. I talk with the parents, but I always focused on the child, and I talk with the child, and the parents are aside, because the child gives more and more information, and I need the therapeutical relationship with the child. And you have to start with the correct diagnosis, and we give a good explanation about the treatment goals and treatment plan. And if you start with treatment, psychoeducation, the biggest part of it, to understanding how the bladder works. Registration is a tool which I will explain later, and the child needs to practice. The child has to follow up some homework. And at the end, you want that the child maintains what he has learned during the treatment phase, and you want to prevent relapse. So if we see standard urotherapy, I'm just looking because I think I'm missing one. As said, the first thing is that you explain the child when you start with urotherapy. Is the child what happens? Why is the bladder not working properly? Why has the child incontinence? So use pictures. And this is also a YouTube movie, or a movie on YouTube we have made, and I think there's no time to see because it's 12 minutes, but I can send it later on again. But this is a movie for children, how to explain how the bladder works and what's important. But at least have some pictures or movies or apps to explain the child how the bladder works. The second step in standard urotherapy is to explain the child how to sit on the toilet, because a good proper position on the toilet will prevent pelvic floor contraction during voiding. And this next step is that the child will have used the bladder diary, and it's not the bladder diary for your diagnosis, but it's the bladder diary which is used as a feedback tool for the child. So the first step is you use your bladder diary for your diagnosis. Is it an overactive bladder? Is it a dysfunctional voiding? And when you explain the child is going home with a bladder diary to see, okay, am I going often to the toilet, and do I stay dry during that day or not? So it's like in the behavioral therapy, used as a registration tool and feedback tool. And explain to the child why it's important to drink enough. We always explain how the bladder works. We use a balloon, but it's also on the movie there that you can see how the bladder works. And that this is important for child's motivations, child's understanding, to follow up the instructions which you gave to the child. And most of the children will be dry, or will be have less problems, will improve when you just start with the explanation. And also for the parents, explain what and why it's necessary to drink enough, and to be aware of their bladder feeling. And we always explain to the child, when you have to go, you are not allowed to postpone. When you feel the urge to go, you have to go. And when standard urotherapy is not successful, and you always give it at least or maximum 3 months time, and then children are coming back, and then it's not successful, the next step is specific urotherapy, which can include more psychological support, and that means that the therapist or the physiotherapist gives more instructions and more has frequently contact with the child. It consists of biofeedback or pelvic floor training. We have also central inhibition training. It's also explained in the appendix of my paper, but in central inhibition training is that we teach children, especially with the overactive bladder, to inhibit their urge. First, they have to learn how often to go, and the second step is that we learn the child to inhibit their urge. This is a difficult part for overactive bladder children, but very useful. And bladder training can be a bladder training that you train on bladder volume, but it can be also a strict program, and that the child is filling the bladder diaries. Alarm therapy can be used. We use it only in the hospital, never in at-home situation for daytime incontinence. But you can use alarm therapy for bedwetting, that's fine. But using alarm therapy at home or at school, we want to avoid embarrassment for the child. So alarm therapy we use only in the hospital. And at least you can use neuromodulation, and for children with severe postvoid residuals, we start CIC. And the main or the key elements of urotherapy is that you teach the child how to void, when to void, and how often to void. And you can use some tools. You can use time voiding, but we use it most time for children with postponement and children with urge incontinence. Bladder training can be given to all subforms of incontinence, and the pelvic floor muscle training with biofeedback is most appropriate for children with dysfunctional voiding, central inhibition for children with overactive bladder, and neurostimulation for children with overactive bladder or urge incontinence, and CIC for persistent postvoid residual, as I said already. And if we look to Nick is 9 years old, and he's coming to the clinic, and his mother tells you that he is every day wet several times during the day. He is wet nights, not every night, 3 times, 4 times a week, and he has also fecal incontinence. And when we do the assessment, we find out that he has urgency, imperative urge. So it's when he feels he's not able to hold. He has small bladder volumes, and he has a really high mixed region frequency. And there is a formula that 30 plus 1 plus H. Well, I expect that every one of you know how to calculate the avoided volume. I wanted to write it down, but I will give it to you later. But he has a small bladder volume for his age, about 100 ml every void, and he has a mixed region frequency of 8 till 10 times a day. But he has also autism and difficulties with his sensory modulation. And when we did the ultrasound and asked them, and we had fecal incontinence, and we found a huge rectum. So he's also constipated. All these elements influence each other. So I can start treating the overactive bladder with anticholinergics, but I didn't want to solve his autism and his awareness of the bladder. And when I start only treating this, I forget the constipation. It will never helpful. So you see, everyone is related to each other. So what does he need? The first thing, ask the child what he wants, involve the child. And when we have a child with an overactive bladder, we want to, at the end, a larger volume, that he is able to master his bladder, and that he has less urgency, that he is able to recognize his bladder and bowel signals, and that he has emptying his bowel every day. So we start with education and instructions, we start with laxatives, and we start with anticholinergics to support his bladder. And we start with urotherapy, with specific urotherapy to explain him and to support him during the weeks to understand what happens and to master his bladder. And the treatment of constipation consists of education and explanation. Again, a toilet program, that means that there is timed stooling. So you ask the child to sit on the toilet after each meal, at least for 5 till 10 minutes. Sitting on the toilet, that's a huge time. It's long for the child to sit that time on the toilet, 5 till 10 minutes. So, and they are not allowed to bring their iPad or tablet or books to sit, but they have to work on the toilet. And a toilet program can never be without laxatives. So you should start laxative as well, and there should be a rewarding system that the child becomes more aware of his bladder and keep motivated to sit every time on the toilet. And when there is constipation, you should treat it at least for 6 months and monitor it as well. And this is for parents also not always understandable when they have the incontinence child. So you have to explain why it's important to continue with laxatives during at least 6 months. And I said that we have 3 elements of urotherapy, of the treatment, or the educational part for children, that we learn them how to avoid, when to avoid, how often. But these elements, they have cover the main goal that we teach the child to learn to react adequately on his bladder signals. And by repeating these practices, we will habituate new avoiding behavior. Now, how do we explain this? How to avoid toilet posture? We can use biofeedback with or without EMG. And teaching different relaxations and contractions, that is the biggest part for physiotherapists. And we can also use the ultrasound to measure the PVR, and also for biofeedback of the pelvic floor. So just going back. And we have the real-time urophilometry. We as biofeedback. So in every when we have the uroflow, we have a screen in front of the child when he sits on the toilet, and can see what type of flow pattern will happens when you sit on the toilet. So our biofeedback consists of real-time uroflowmetry, but it can also be done by the physiotherapist with feeling and anal balloon expulsion. And we explain to the child that you sit and listen how the stream is going out. The ultrasound, it's a non-invasive assessment, and everyone can use it, physiotherapists, nurses as well. And it's also a useful feedback tool for the child and the family. So you can see if there's a full rectum or is an empty rectum, and they can explain if there is a post-void residual. And ultrasound for the pelvic floor, we do the dynamic ultrasound, the perineum. We put the probe on the perineum, and then you can see if the child is properly contracted the pelvic floor or not. And this is a very useful tool. You need some experiences, but I know a lot of children now in the Netherlands, they have had physiotherapy in the first line, and they are taught to contract and to relax the pelvic floor. And when we do the ultrasound, a lot of children, they have any clue how to contract or to relax the pelvic floor. So with the biofeedback and the ultrasound, it's a useful tool to show the child what's happening. And Janet Chase, she is a physiotherapist from Australia. She has been in the ICCS board as well. She wrote an excellent paper about the pelvic floor and what we can learn, and how to use also the ultrasound for pelvic floor assessments. And the pelvic floor muscles is necessary. And we do the pelvic floor muscle training. Pelvic floor muscle training is different as biofeedback training. Biofeedback training, then you teach the child to void properly, but pelvic floor muscle training, then you teach relaxation. And only in cases of congenital dysfunctions, we teach muscle strength and endurance. And since last years, I'm treating so many children, I'm less convinced that the pelvic floor is one of the key factors of incontinence. I did research with one of my with my colleagues, and it's not high quality because it was retrospective, but we showed that only pelvic floor rehabilitation or only pelvic floor training did not solve incontinence. The whole program of urotherapy with behavior and changing habitudes was more helpful to become dry than only pelvic floor. And we are currently doing a study with children who have been treated in the 19s and now they are adults and still they have dysfunctional voiding. So I'm not really sure if the pelvic floor is one of the key factors. It's part of the incontinence, but it's not the key factor of incontinence. We teach them when to void, because it's that's why they have to follow a bladder diary to see how often and when they are going to the toilet, and they can get a positive and negative reinforcement. So if they become wet, they can draw a cloud on the list, and if they become dry, they will draw a sun. So the many suns, the more they winning the game with themselves. How often to void? It's depending on the diagnosis, more or less often. In case of hypoactive bladder or postponement, we use often time voiding. But in children with overactive bladder with a high frequency, it's not really needed to focus that much. We use urotherapy has its basis in cognitive behavior therapy, and those are some terms of the cognitive behavior therapy: psychoeducation, registering, positive reinforcement, and shaping. And these elements we use that also during the training. As you see, keeping a bladder diary is registering, explaining how the bladder works and what the bladder dysfunction means is psychoeducation, and to achieve the behavior in small steps, it's shaping in the cognitive behavior therapy. A lot of children have behavioral problems, and it will also influence. So like today, I had a girl of 10 years old. She was treated for constipation. She had daytime incontinence, and she's now 10 years old, but none of the treatments were successful. They were for a small period successful, and then she all the time falls back. And the mother asked me today, I suppose that she has also ADHD, and I said, yeah, that can be a factor why it's the therapy is failing. So knowing if there is ADHD is helpful for your treatment. You cannot solve it, but if you have a child with ADHD or ADD or autism, be aware that you not start too early, but at least at the age of 8 or 9 years old, because these children has much more difficulty to follow up the rules. And when we start with urotherapy, then is a follow-up period needed that is needed to support, to increase the motivation, and it will be done by frequent contact. Nowadays, it can also be done by telemedicine, and we repeat all the time the child what to do and what they have to learn, and we support the parents. And at the end, after 3 months, we will see the children back in our clinic, and we will evaluate our treatment by how many incontinence episodes are existing, how many urge episodes exist, what's happened with the UTIs, are they still there or are they relieved, is there still fecal incontinence, and you will measure it by bladder, by signs, like bladder emptying, is the post-void residuals decreased, is bladder wall changes, and is flow pattern normalized when there is dysfunctional voiding, for example. And all the time you have to check child's motivations, child's understanding, and the psychosocial effects of incontinence. And is child able to generalize his proper voiding and bowel behavior? Now, I already said that you at least treat at 3 months. It's what is the best treatment duration? After 3 months treatment, you should always re-evaluate or evaluate how it's going on, and if there is improvement, you have to check for constipation, and if standard urotherapy is not successful, you can continue with specific urotherapy. But what to do with treatment-resistant cases? Again, reconsider your diagnosis. Have you done the right diagnosis? It's often happens to me that our children are referred to me, that the pediatrician said, well, it's dysfunction avoiding, and then it's an overactive bladder. And children with dysfunction avoiding and treated with pelvic floor muscle training can have benefits, but when you have a small bladder, you won't have benefits of pelvic floor muscle training. And you have to think about what kind of urological causes can be still there, or the psychosocial causes can be influence and a disturbing factor for your treatment. What are more disturbing factors? You as healthcare provider, that we start with the wrong diagnosis or treating too long, and there is no motivation of the child anymore. The child's factors could be immature. It can still denial of the wetting accidents, or there can be behavioral problems and no motivation or understanding. And if the child has no motivation to follow up the urotherapy program, I stop and I said no one will die from incontinence. So it's a social it has a social impact, but if you don't want to follow up my rules and don't want to work together, I cannot treat you and you can come back later. And it sounds very strict, but it's helpful for the child's understanding. And another disturbing factors could be parents. They could be interfere with the treatment. They can show their frustrations, or they can show that they have no confidence in the child, and this will absolutely has an impact on the child. So that can be one of the reasons why the treatment also failed. We said CIC is one of the steps what you will do when you have persistent post-void residuals, or when you have shown with the invasive urodynamics that there is really weak detrusor. Then we start clean intermittent catheterization, and we teach children from the age of 5 years old to do it by themselves, and that's absolutely useful. When children learn to do them, to catheterize themselves, they are more motivated to hold on, and they are more independent, so they don't need parents all the time. And neuromodulation, to be honest, we don't use neuromodulation, but there are also clinics in the world. They have not the possibility for bladder training programs, and for children with an overactive bladder, we know that neuromodulation can be useful and successful if it is given with medication. For daytime incontinence, for bedwetting, it's not that useful. What makes urotherapy successful? To understand the combination of different elements, the multidisciplinary approach, and that you have focused attention for the child's problem and the therapeutic relationship. And why do you need a urotherapist? A urotherapist has much more experiences, and it has a major impact on the treatment. The urotherapist is able to observe, to watch, and to read the child, and he has the knowledge and the understanding of the urology, and also the knowledge and the understanding of the psychology. And a urotherapist can be a nurse, pediatric nurse, can be a physiotherapist or a psychologist. They all perform urotherapy. So you can say they are urotherapists. But educational programs are needed to teach nurses or physiotherapists in a good way for urotherapy. So urotherapy in science and society, we know that urotherapy is successful. Standard urotherapy has a success rate of 56% versus 50% spontaneously solution. There is done by the German group. They did a meta-analysis and they proved this, gave these results. And specific urotherapy, there are many papers about specific urotherapy, and they show a success rate about 60 to 80%. So urotherapy is successful, but till today we didn't know exactly what makes it successful and what kind of treatment is the best for each different subtypes. And that is also one of the reasons that the urotherapy is performed by different professions, that we are not having not that we don't have the right or the uniformity in terminology, and that treatment outcomes are reported more often, but protocols still differ. So when you read the paper out, treatment of urotherapy, you can see, well, we gave instructions, that's it. But what kind of instructions, how long, how many times, we don't know. So if you want to publish a paper out, treatment of daytime incontinence with urotherapy, please describe also your protocol so that we can compare. Your specific urotherapy includes biofeedback and includes neuromodulation, but it is part of specific urotherapy. But what we also know is that urotherapy is often intensive and lengthy. And I don't think it's the reason why it is intensive and lengthy is that we sometimes start too early, a lot of children with 5-6 years old, and that you need more time, and it's make perhaps also urotherapy expensive. But that is what I want to figuring out with our next study. We will start with a multidisciplinary or multi-center study in urotherapy in the Netherlands upcoming months, and then we also will compare the costs of urotherapy between different centers. Thank you for your attention. Are there any questions?
Well, Anka, thank you very much for this nice presentation. So I will stop your sharing here. And let me highlight myself as well. That's both lines. Yeah, okay. I'm sure there will be some questions for you, but I would like to add another spotlight. Okay. Yes, if there are questions, please go ahead and please click the button on raise hand so I can be able to unmute you to ask your questions.
I see one question in the chat, and there is a question. Do you think there is a role for urotherapy for nocturnal enuresis? Yes, there is a role, absolutely. Because treating bedwetting is also a lot of explanation and support and guidance. So when we wrote the definition paper about urotherapy, one of the reviewers said, well, it's not really needed urotherapist, but we gave the feedback that it is not really needed because you can treat children with bedwetting with Min-Rin as well, or bedwetting alarm, but the correct support and information can be done by urotherapist.
Okay. Let me ask you a question, Anka. Who's referring the patient to you, the pediatric urologist, or do you yourself examine or evaluate the patient and decide the indication and lead the therapy, or you all do it this urotherapy as a team?
We do it as a team, but every child who I or my team sees have been seen by the urologist for physical examination. But to be honest, I see we are sitting in the same room and we do both the assessments together, and the urotherapist, they do also the ultrasound. But the first step in our center is urologist, then urotherapist. And I know in other hospitals in the Netherlands, it's often the pediatrician and then the urotherapist. But some of the urotherapists can be also nurse practitioners, and they're allowed to do physical examination as well and prescribing medication. It's depending how you are organized.
Okay. So since there are no questions, I would like to ask you one more question. I know that you're also a psychologist. Is it correct? Yes.
Yeah.
So what is the coexistence of obsessive compulsive disorders in these kind of children or in their parents? What's your observation?
I cannot say that there is no. There are some children, parents they have, but not as often as ADHD or what else. But that's why I'm so saying that the explanation about what happens with the bladder and what happens with the bowel is so important, because a lot of parents complaining, or they think my child is not listening, or they are focused on the bladder too much, but sometimes it's also their coping mechanism to handle their bladder problems. So the coexistence, I have no numbers, and they are not that high.
Okay. There is a question coming from chat from Aygül Köseoğlu. She's asking, is there an approach you add to urotherapy in giggle incontinence?
Funny. Yes, okay. I got today a question from some colleague from Georgia. What do you do with giggle incontinence? To be honest, giggle incontinence, I found these the most difficult group. There are a lot of there are a few papers, and on the ICCS meeting in October, they also show that methylphenidate is a successful treatment for giggle incontinence. We don't use that. We prescribe methylphenidate for these children when there is solely giggle incontinence. So the first step is that you really must be assured that there is solely giggle incontinence, because a lot of children has also a combination of stress incontinence and giggle. And when there is stress incontinence, we will provide them with the urotherapy program. But with the giggle incontinence, we ask the pelvic floor of the physiotherapist for pelvic floor to teach the pelvic floor contractions. And sometimes we prescribe methylphenidate, but not all the parents have the preference for that. And our urotherapists are careful to prescribing methylphenidate, because they say we are not a pediatrician or not a psychiatric. But I know from Alexander von Contat, he's a psychiatric and treating a lot of children with incontinence. He always prescribed methylphenidate.
Another question coming from the chat from Dr. Dokucu, and he's thanking you for this nice presentation, first of all. And he's asking, you told you don't use alarms at home, but only in hospitals. He's wondering, do you hospitalize the kids for the alarm use? If so, how many days?
Yeah. We admit them, and we are in the Netherlands the last resort for these children. So we are the third line care center. We have a luxury position, because I think no one in the world will admit these children for at least 10 days. We have a program for 10 days. So if the children has had all the treatments elsewhere, and we were absolutely sure that there is functional incontinence, we admit them. They have a strict program, and that's also why we don't use neuromodulation, because our program is very successful in these children. We have a success rate about 70-80%. But I know we have a luxury position, and it is from history based that we can admit them.
Well, Anka, I'd like to thank you very much. First of all, accepting to give a conference in a short notice. And thank you for this nice presentation. Right now, Professor Murat Çakmak, he's the director of our clinic department of pediatric surgery at Ankara University. I will give him the word for his remarks and the closure. So thank you for everything once more.
Thank you. It was my pleasure.
Professor Çakmak.
Yes, thank you, Aydın. Dear Dr. Anka, thank you for your nice presentation. This is a hard subject, but there's a meaning for us also. This year is the 40th year of our clinic's foundation year first. And after that, this is the first scientific meeting of the Pediatric Surgery Department's foundation after 1 month, and this is meaningful for us also. And thank you very much. We will continue these subjects and these meetings in the future also. And if you give more explanations about this urotherapy or nearly subjects like this, we will be very grateful to you. Thank you very much.
Thank you. It's an honor. Thank you very much.
Sevgili hocalarım, değerli arkadaşlar, meslektaşlarım, bizim için bu sene önemli bir sene. Kliniğimiz 82 kuruluşlu, 40. yılını bu yıl kutluyor. Bu yıl çocuk cerrahisi artı çocuk ürolojisi olarak götüreceğimiz bundan sonraki bütün ortak toplantılarımızı oluşturmaya devam edeceğiz. Muhtemelen yaz sonu gibi bir 40. yıl bilimsel toplantısı da ardı sıra gelecek. Bu toplantının da yine kliniğimizin neredeyse en çok uğraştığı konulardan olan postponement, intersex ve laparoendoskopik cerrahi birlikteliğini içine alan özellikle asistan arkadaşlara yönelik bir toplantı olarak devam edecektir. Bunu da hani sizlere iletmekten mutluluk duymaktayım. Teşekkür ederim hepinize katıldığınız için.
Okay, thank you everybody and have a good night. Bye-bye.